This lecture will review the critical illness-related corticosteroid insufficiency. Thank you for listening to Acute Care Surgery Nerds. This talk is based on a two-part article. The first section that came out in December 2017 by the SCCM and ESICM, and the second part came out in January 2018. This is an update from the 2008 statement. The expert panel is made of 16 international experts from medicine, endocrinology, and critical care medicine. Recommendation approval required agreement of at least 80% of the task force. The task force met 4 times in person since January 2014 to January 2017. The concept was revisited because of 2 main reasons: the recognition of the importance of evidence-based approaches to care to improve the quality, safety, and establish a transparent framework for service. And second, there's a widespread use of corticosteroids in critically ill patients. Therefore, there's a need for a valid, reliable, and transparent process of the evaluation to support key decisions. When creating the recommendations, the task force considered the quality of evidence, the balance of desirable and undesirable consequences of compared management options, the assumption about the patient's values and preferences associated with the decision, and the implications for resource use and health equity, and the acceptability of the intervention to the stakeholders and the feasibility of the intervention. Interventions were given a strong recommendation, which is a quote, "we recommend," or a conditional weak recommendation for the quotation, "we suggest." Critical illness-related corticosteroid insufficiency, which I will now call CIRCI, is a concept first introduced in 2008 to describe impairment of the hypothalamic pituitary axis during critical illness. It is characterized by dysregulated systemic inflammation resulting from inadequate intracellular glucocorticoid-mediated anti-inflammatory activity for the severity of the patient's critical illness. For this lecture, I'm going to review the recommendations for diagnosis of CIRCI and the recommendations for corticosteroid use in critical care conditions. The task force makes no recommendation regarding whether to use delta cortisol, such as a change in baseline cortisol at 60 minutes of less than 9, or cosentropin administration, or a random plasma cortisol of less than 10 for the diagnosis of CIRCI. There are inconsistencies in other guidelines. The most recent Surviving Sepsis Campaign guidelines of 2016 suggest that neither the random cortisol or ACTH stim tests have been useful in identifying adrenal insufficiency and septic shock. The Endocrine Society suggests that the high-dose 250 mics ACTH stimulation test is superior to other existing diagnosis tests to establish diagnosis of primary adrenal insufficiency with peak cortisol levels below 18 at 30 or 60 minutes, indicating adrenal insufficiency. There's only one single-center randomized trial that compared low-dose ACTH 1 mic stim test, a high-dose ACTH 250 mic stim test with a random cortisol for the diagnosis of adrenal insufficiency, and this comes from 2008. There's only 59 patients. They determined that compared with total random cortisol, low-dose ACTH test was better able to predict a longer duration of vasopressor requirement and hemodynamic response to corticosteroids. 67% met criteria for random cortisol, 22% by low-dose test, and 8% by high-dose test. Yet of patients that responded to steroids, 95% had a baseline cortisol less than 25. 54% were found with low-dose ACTH tests, and 22% diagnostic by the high-dose ACTH test. This is a 2014 article from the Journal of Trauma and Acute Care Surgery. This is a multi-center prospective cohort study that evaluated trauma patients and checked a baseline cortisol level, then gave an ACTH stim test on different days during the hospital course, and followed up the cortisol response. CIRCI was diagnosed with a baseline cortisol of less than 10 or a change less than 9. They found that 54 patients were diagnosed with CIRCI. The ACTH stim test identified more patients than random cortisol, and the authors found that a change in cortisol less than 9 was an independent risk factor for death, but not a random cortisol less than 10. In regards to these findings, the task force makes no recommendation based on the risk of bias in study designs and the small number of prospective studies and low numbers of patients. There were 2 rounds of voting on the subject, and they could not reach a 80% consensus among the task force. Therefore, this is the result. They found that it's unlikely that a single test can reliably diagnose CIRCI, independent of its mechanisms such as altered cortisol synthesis or metabolism or tissue resistance to cortisol. Free cortisol is the bioactive form of cortisol, while plasma total cortisol is affected by cortisol-binding proteins. Critically ill patients often present with hypoalbuminemia and low serum concentrations of cortisol-binding globulin. There are only a small number of low-quality observational studies with inconsistent findings comparing the total or free cortisol. This is a 2011 prospective cohort article evaluating 112 patients in mixed ICUs with treatment-refractory hypotension. Patients were given a high-dose 250 mics ACTH test, and free and total cortisol levels were assessed. They found a good correlation of R 0.77 to 79 between free cortisol levels and total cortisol levels. The study looked at septic patients, Table A and C, and non-septic patients in Table B and D. They also asked the question if the albumin level would affect the correlation between the free and total cortisol level, and found that the increases in free cortisol depended upon less on low binding proteins than raw levels of free cortisol, so that increases in total cortisol suffice in assessing adrenal insufficiency. Due to correlation of some studies and some low quality and small number of evidence, the task force recommends against using plasma-free cortisol levels because of the lack of availability of the lab in hospitals and the unlikely rapid turnaround time that is necessary. In saliva, cortisol is unbound and may inform on levels of free cortisol, yet there's confounding factors such as gender, age, time, site of sampling, and the volume of saliva. Example is that in one study had to exclude approximately a third of patients because the sample they received either was not saliva or not enough saliva. This is a 2010 prospective observational article from France that evaluated 88 cirrhotic patients and looked at salivary cortisol, free cortisol, and total plasma cortisol levels. Patients were admitted for a complication from their cirrhosis and were tested with an ACTH stimulation test. They looked for the correlation between the different cortisol labs. Free cortisol was calculated using the Coulin's formula that uses cortisol binding globulin levels and serum total cortisol. This study found that free cortisol level correlated better with salivary than total free cortisol levels. Similar results were seen in other studies, but the task force felt that using salivary cortisol by enzyme immunoassay would not be cost-effective, practical, or feasible in some institutions. Therefore, they suggested against using it. Is the 1 microgram ACTH stimulation test superior to the 250 microgram ACTH test for the diagnosis of CIRCI? A 2012 article from Hormone and Metabolic Research looked at 74 septic shock patients with low and high dose ACTH stimulation tests. They gave the patient 1 microgram of concentropin, then measured the cortisol level. Then 4 hours later gave a 249 microgram of concentropin, then again measured the cortisol level. They found a moderate correlation, R2 value of 0.55, between low and high dose ACTH stimulation tests, where baseline cortisol level was between 10 and 34 micrograms. They conclude that both tests could be used to diagnose CIRCI. This is a 2016 study from the journal Clinical Endocrinology and Metabolism, and they performed a meta-analysis of 30 studies that examined low and high dose ACTH tests for adrenal insufficiency. Given that this study did exclude patients with critical illness, it did show that a low and high dose ACTH stimulation test had similar diagnostic accuracy. The supraphysiologic dose of ACTH may result in significant stimulation of the adrenocortical cells in patients with proven adrenal insufficiency. Therefore, it was thought that a 1 microgram ACTH test may increase the sensitivity. Additionally, the ACTH ampules come in 250 micrograms per bottle, and to perform the low-dose test takes some preparation, therefore takes extra work to administer. The task force suggests that a high dose rather than a low dose stimulation test be used for the diagnosis of CIRCI. Is hemodynamic response to hydrocortisone superior to the 250 microgram ACTH stimulation test for the diagnosis of CIRCI? Currently, there are no studies that directly address this specific question, comparing the prognostic value of hemodynamic response to hydrocortisone versus the 250 microgram ACTH test for the diagnosis of CIRCI. Previous studies have found that hydrocortisone may improve the vasopressor response to norepinephrine in septic patients, this effect being more pronounced in patients with a CIRCI. Also, studies such as the Corticosteroid study showed that shock resolved quicker in patients with or without CIRCI whom were given hydrocortisone. Also, the Hypres study, meaning hydrocortisone for the prevention of septic shock, did not find a difference in the development of septic shock in the presence or absence of CIRCI. Yet there are no studies evaluating this question, so the task force made this recommendation to suggest the stimulation test rather than the hemodynamic response to the hydrocortisone for the diagnosis of CIRCI. Corticotropin and cortisol usually change in opposite directions. In primary adrenal insufficiency, plasma cortisol is low and corticotropin is high. In hypopituitarism, plasma cortical levels are low and corticotropin levels are low or normal. Yet in critical illness, plasma corticotropin levels have been variably low, normal, or high, and likely follow a dynamic pattern with transiently elevated levels and subsequent decline over a period of weeks after the initial insult. There have not been any studies to compare the diagnostic accuracy of corticotropin levels with that of the ACTH stimulation test. Owing to the complexity of the lab, the task force deemed that it is not feasible in most institutions to obtain corticotropin level with short turnaround time to have an impact on the acute management of the patient. Next, we will go into the recommendations for corticosteroid use in critical care conditions. The task force suggests against using corticosteroid administration in adult patients with sepsis without septic shock. Pro-inflammatory cytokines have been demonstrated to either suppress cortisol response to ACTH or compete with intracellular glucocorticoid function, which can result in CIRCI in septic patients and further precipitate organ dysfunction. This was a study in November 2016 from Germany. It was a multi-center, double-blind, randomized clinical trial that included 380 patients with sepsis without septic shock. Patients were given either 200 milligrams of continuous infusion of hydrocortisone for 5 days, then given a taper until day 11 versus a placebo. The primary endpoint was the development of septic shock. The primary outcome was development of septic shock within 14 days. Patients who received hydrocortisone showed no difference in rates of progression to septic shock within 14 days from those given placebo. Additionally, there was no differences between the hydrocortisone and placebo groups for the use of mechanical ventilation, mortality, ICU length of stay, and hospital length of stay. Yet in the hydrocortisone group, 21.5% versus 16.9% had secondary infections, 30.7% versus 23.8% had muscle weakness, and 90.9% versus 81.5% had hyperglycemia. Based on these results, the task force members agree that corticosteroids may not be beneficial in adult patients with sepsis without septic shock. Should corticosteroids be administered among hospitalized adult patients with septic shock? The task force suggests using corticosteroids in patients with septic shock that are not responsive to fluid and moderate to high dose vasopressor therapy. And the follow-up question, what is the recommended dose and duration of treatment among hospitalized adult patients with septic shock treated with corticosteroids? The task force recommends using a long course and low dose treatment rather than a high dose and short course in adult patients with septic shock. A Cochrane review in 2015 evaluated hydrocortisone for treating septic shock by looking at 33 randomized controlled trials with a total of 4,268 patients. They found that corticosteroids reduced the risk of death at 28 days by 13% among 27 trials. The survival benefit was dependent on the dose of the steroids, saying the lower dose, less than 400 milligrams a day, for a longer duration of 3 or more days. Corticosteroids increase the chance of recovery from septic shock by day 7 in 31% of patients and decrease organ failure rates. ICU length of stay was decreased in patients with corticosteroids, and the main adverse effects were hyperglycemia and hypernatremia. Within this topic of administration, dose, and duration of corticosteroids for septic shock, the authors mention which steroids should be used. This is the article cited. A meta-analysis that was published in March of 2017 finds that there was no clear evidence for superiority of one type of corticosteroid over another, yet hydrocortisone boluses and infusions were more likely than methylprednisolone boluses and placebo to reverse shock. This is the network plot in the paper. Basically, the thickness of the line and the node correspond to the number of patients in the study. There was strong evidence that boluses of methylprednisolone are less likely to result in shock reversal than hydrocortisone. There was also evidence that hydrocortisone increases the likelihood of shock reversal compared with placebo when given as a bolus with an odds ratio of 2.34 or as an infusion with an odds ratio of 3.68. Due to these findings, the task force made their recommendations, yet they were not able to comment on pediatrics, as there is a paucity of literature regarding this issue. There are pilot studies such as the STRIPE study, meaning steroids in fluid or vasoactive infusion-dependent pediatric shock. It's looking at the role of steroids in the treatment of pediatric shock. And there's other studies such as the ADRENAL study from Australia and New Zealand that's evaluating hydrocortisone versus placebo in septic patients. So should steroids be administered among hospitalized adult patients with acute respiratory distress syndrome? A meta-analysis of the 4 of the largest studies was conducted in 2016. These are the 4 studies: methylprednisolone infusion in early severe ARDS in 2007, effects of methylprednisolone in early ARDS in 2013, effect of prolonged methylprednisolone therapy in unresolving ARDS in 1998, and efficacy and safety of corticosteroids for persistent ARDS in 2006. A patient data analysis of 4 of the largest trials comprising 322 patients investigated and found that early and late methylprednisolone treatment showed improved survival and decreased duration of mechanical ventilation. With the exception of hyperglycemia, prolonged glucocorticoid treatment was not associated with increased risk for neuromuscular weakness, GI bleeding, or nosocomial infections. Given this study, along with others, the task force suggests that methylprednisolone be considered in patients with early ARDS in a dose of 1 mg per kilogram, and in late persistent ARDS, which is greater than 6 days, in a dose of 2 mg per kilogram, followed by slow tapering over 13 days. Compared to early versus late initiation treatment, the early treatment is associated with faster disease resolution, as you are beginning treatment when the fibroproliferation is still in the early stages of development. Methylprednisolone is suggested because of its greater penetration into lung tissue and longer residence time. For major trauma, should corticosteroids be administered among hospitalized adult patients with major trauma? There have been 19 trials that investigated corticosteroids on short-term mortality in adult patients with multiple traumas. This involved 12,000 patients. The mortality for the corticosteroid group was 26.9%, and for the placebo group, 23.5% with a relative risk of 1. There was a trial that looked at trauma patients diagnosed with CIRCI by an ACTH stim test who received hydrocortisone. It was a French multicenter randomized double-blind placebo-controlled trial called Hippolyte, Hydrocortisone Polytraumatized. They had only 150 patients, of which 76% had CIRCI. They found that patients who received steroids had more mechanical ventilation-free days and had fewer cases of hospital-acquired pneumonia. The task force recognized the type of patient, formulation, dose and duration of corticosteroids to vary widely across trials, yet the overall pooled effect showed no effect on mortality. Yet they also recognized the quality of the evidence for this specific question to be low and that there may be potential for clinically important side effects to steroids. Therefore, they made the conditional recommendation against the use of steroids in major trauma. For community-acquired pneumonia, should corticosteroids be administered to hospitalized adults with community-acquired pneumonia? There have been 13 trials, including 2,005 patients, addressing this question. There was a meta-analysis in 2015 referenced in the guidelines. 12 of the trials suggested a mortality reduction most pronounced in patients with severe rather than mild pneumonia with a relative risk of 0.67. Severe pneumonia was defined by any of multiple scoring systems, including the Pneumonia Severity Index, the CURB 65 score, IDSA guidelines, etc. Additionally, corticosteroids were found to shorten hospital stay, reduce the need for mechanical ventilation, and prevented ARDS with a relative risk of 0.24. Given the evidence across outcomes was moderate, and given the consistent signal for benefit, the task force agreed that the beneficial effects of treatment with corticosteroids outweighed the risks. Therefore, they suggest the use of corticosteroids for 5 to 7 days at a daily dose of less than 400 milligrams IV hydrocortisone or equivalent in hospitalized patients with community-acquired pneumonia. Influenza is mainly driven by uncontrolled inflammation. There were only 13 observational studies, including 1,917 patients, that evaluated this topic. The overall odds ratio of dying when corticosteroids was administered was 3.06, and there's an increased risk of superinfection in these groups. The quality of evidence was very low because of the absence of any randomized controlled trial. Given the evidence and findings with the risk of corticosteroids, the task force made a conditional recommendation against the use of steroids for influenza. Should corticosteroids be administered to hospitalized adults with bacterial meningitis? A Cochrane review from 2015 analyzed 25 trials involving 4,121 patients, of which 2,511 were children. The relative risk of death was 0.9, yet not significant. Severe hearing loss and neurological sequelae were decreased in the corticosteroid patients, yet mortality was only decreased for Streptococcus pneumonia meningitis and severe hearing loss only for Haemophilus influenza meningitis. Given that hearing loss and neurological sequelae are highly relevant, they justified a strong recommendation to use corticosteroids in patients with bacterial meningitis, despite the lack of strong evidence for a mortality benefit. Should corticosteroids be administered in adult patients undergoing cardiopulmonary bypass surgery? This is a randomized controlled trial from 2012 that was in JAMA. It is called the DEX study, meaning dexamethasone for cardiac surgery. It was a multi-center randomized double-blind placebo-controlled study comparing patients that received high-dose dexamethasone intraoperatively versus a placebo. About 4,482 patients were evaluated. The relative risk for the composite endpoint was 0.83, just barely not significant. Composite endpoint was death, myocardial infarction, stroke, renal failure, or respiratory failure. The superinfection relative risk was 0.64, and respiratory failure relative risk 0.69 in favor of dexamethasone. Atrial fibrillation was slightly lower in the dexamethasone group, yet not significant. Consistent with other studies is the finding of high serum glucose concentrations. Given that the evidence points towards benefit, though not significant for mortality and atrial fibrillation, they suggest the use of perioperative corticosteroids in adults undergoing cardiopulmonary bypass. The quality of the evidence was downgraded to moderate as there was imprecision for mortality outcome and inconsistency across the trials for atrial fibrillation. Should corticosteroids be administered to adults who suffer a cardiac arrest? An analysis of 3 trials showed shock reversal with a relative risk of 1.42, survival to hospital discharge relative risk 1.96, and good neurological recovery at hospital discharge relative risk of 1.45 in favor of steroids. This is a study from July 2013 that looked at a cocktail of medications including vasopressin, methylprednisolone, and epinephrine versus just epinephrine alone in the control arm and a randomized double-blind placebo-controlled trial in Greece. The trial involved 268 patients. If the patient was in shock after ROSC, they were given a continuous infusion of hydrocortisone. They had an odds ratio return to spontaneous circulation of a relative risk 2.98, survival to discharge with good neurological outcome, relative risk 3.28. The authors think that steroids may potentiate the effect of vasopressin. Owing to the benefits in terms of shock reversal, survival to hospital discharge, and good neurological outcome, and to the absence of evidence for complications, The task force suggests corticosteroid use in cardiac arrest. The quality of evidence was downgraded to very low owing to imprecision and indirectness, given that the corticosteroids are one component of the cardiac arrest cocktail in 2 trials. This concludes the lecture regarding guidelines for the diagnosis and management of critical illness-related corticosteroid insufficiency. I recommend you read these guidelines yourself, make your own judgment. And again, thank you for listening to Acute Care Surgery Nerds.